Well, welcome
So,
everybody. So Tony, who's the mastermind behind all of this, has the questions teed up on slides. So let's start with Lisa J's question. So Lisa's son um, was born with a couple of issues, but the most recent one that we was dealt with was a bad aortic valve. So we did I did what's called a Ross operation. And for those of you that don't know what that is, that's where you take the pulmonary valve, so the valve that connects the right ventricle to the lungs, and you take it out and switch it over into the aortic position and make it the child's aortic valve. And then to replace the explanted pulmonary valve, you use what's called a homograph. So that's a cadaver valve from somebody that's died, and you use that to replace the pulmonary valve. And the advantage of that operation, there are a lot of advantages of that operation, but one is that the new aortic valve is the kid's own tissue, so it performs better than any prosthetic valve. It grows with the child, which is unlike any other valve. It has um, better hemodynamics, meaning blood flows through it better than any prosthetic valve. Um, and it usually lasts a long time. Now, the reason for this question is that this one is having some issues, but and the other thing is that it doesn't require any blood thinning at all, no medications. So it's a big operation, though, the Ross operation, which is why some people avoid it, because it's a huge operation. So Lisa's question was that my son's neo-aortic root is dilated. So that means the new aorta, which used to be the pulmonary artery, which has the valve in it, is getting larger. Why might this be happening? Is it common? What's the procedure for correcting this? And if it can't be corrected, it was told us that sometimes metal valves are put in, and then the question of blood thinners comes about. And then as we move forward with an MRI and a follow-up appointment, what should I be asking, and who should be doing this type of operation? So Tony, I think you can take away the slide. Um, so let's start in the middle, Lisa. So a couple of things. I looked at the echocardiograms that you sent me, um, and it's important to recognize, first of all, for a leaky aortic valve, no matter what kind of leaky aortic valve is, whether it's the kid's own aortic valve, whether it's a new aortic valve, a prosthetic valve, a Ross valve, whatever, the indications for an operation are not based on the degree of leakage. So that's a common misconception. And some people like to pull the trigger based on leakage. So we talk about leakage as mild, moderate, or severe. And some people say, oh, as soon as it's moderate or severe, we need to do something. That's just not true. People can live with severe aortic valve regurgitation or leakage for a long time. So the trigger for an operation is what consequences there are from that leakage. And in the case of a leaky aortic valve, it's a dilating left ventricle, meaning the left ventricle gets larger. So the reason I asked you to send me both the most recent echo and the one previous to that, so I think they were January and July, something like that, is to compare the left ventricular sizes on the two. So his left ventricular size right now is a little bit larger than normal. There's no question about that. And it's also, if you look at the two echoes, and I just have the reports, I don't have the echoes, but it's a little bit larger than it was in January. So the July echo is a little bit larger than January. But it's also important to remember that echoes are just one point in time. So if you look at some of the other measurements on the echocardiogram, they don't make sense, because in the July echo, the size of the aorta, you talk about the aortic root being dilated, the aortic root is less dilated in July than it was in January. Now, that doesn't mean it shrank. That also doesn't mean the aortic valve leakage is worse. It doesn't mean the left ventricle is bigger, because when someone measures the size of a left ventricle or the size of an aortic root, it's one measurement amongst a zillion images, and it depends on what phase of the cardiac cycle they caught it in, who's doing the measurement, where they're putting those little calipers on the echo screen. Like, little tiny difference can turn out to be significant on an echocardiogram if you just look at one echocardiogram. The other thing is that there's a little bit of a discrepancy between some of the descriptions in the text and some of the descriptions in the conclusions as far as the degree of aortic valve regurgitation. So again, aortic valve regurgitation, although you don't operate based on whether it's mild, moderate, or severe, the calibration of whether it's mild, moderate, or severe is also a subjective thing for the most part. I always used to joke with the cardiologists, it's trivial to severe depending on who's reading it. But there are some objective criteria, and one of them is called retrograde flow of blood in the descending aorta. You don't have to worry about what that means or that jargon. It just means that there's something they look at in another part of the aorta to assess whether or not the valve regurgitation is at least moderate. And he doesn't have that. So it's not at least moderate in my estimation. So again, it depends on the size of the left ventricle. So why they want you to get an MRI, and I'm hypothesizing here, is that because they're not sure about the echo readings, they want another test to see how big the left ventricle is. And some people think that an MRI is a better test to assess the size of the left ventricle. I'm not sure that's true, but it's not harmful. The problem with one MRI is that, again, it's one MRI. So it's one moment in time. So if it was my kid, I wouldn't subject him to another operation unless I saw another echocardiogram at some distance from the July one. So like whatever, 3, 4, 5, 6 months from July, there needs to be another echocardiogram with the left ventricular measurement. If it's continuing to go up, fine. Then you can say, well, this is probably real. But if it's back down again, or it's the same, then you really have to question whether or not an operation is warranted. The one caveat to all of that is the function of the left ventricle. You never want to wait until the left ventricle is not working well, because then you've waited too long. And the risk of the operation, you still do it, but the risk becomes higher. His left ventricle is working just fine. So that's not an issue right now. But in terms of the indications for an operation, it's the size of the left ventricle. Now, let's see, your other question. Well, first of all, why might it be happening? I don't really know. Sometimes it happens. It's a little bit more, it's not common at all. It's a little bit more common if the original indication for the operation was a leaky aortic valve as opposed to a stenotic or a tight aortic valve. And I don't actually remember in Bowen's case what it was. I'm sure you do, but it doesn't really matter at this point. If it's leaking, it's leaking. And if it can't be corrected, I was told that sometimes metal valves are put in. Yes, that's true. And metal valves mean a blood thinner, which is the whole reason you try to avoid them in the first place and do the Ross operation. Because blood thinners are frankly a pain in the butt. They hamper your lifestyle. They require frequent blood tests to monitor the level of thinning of the blood. Especially teenagers are notorious for missing meds, and you can't miss these meds. And so it's just painful to have it. If you have to, I mean, there's plenty of kids out there with metal valves and they manage fine. I don't want to scare you, but at the same time, it's way better not to have a metal valve. And the other problem with a metal valve in someone his age is that it's not going to grow. And so the minute you get a metal valve, the clock starts ticking for another metal valve, because he's not going to get an adult-sized metal valve at this age. So it's highly preferable, if an operation is necessary, to repair the leaky valve. Now, repairing a leaky Ross valve is different than repairing a leaky valve that someone was born with, and the surgeon needs to know how to do that. So I'm going to just say this as politically correctly as I can, but you need to find a surgeon that has experience with that. I don't, like, the whole surgical landscape at BC Children's has changed in the last year. I only know one of the people there, and I'll just say he doesn't have any experience with this. I don't know the other two people operating in terms of what experience they do or they don't have, but you frankly have to ask them what kind of experience they have with this. And if they have it, great. And if they don't, then find someone that does. Because it's way better if someone can fix this valve. And there's, most of the time, these valves are fixable if you know how to do it. Does that get everything? Okay. Anything else? Okay. All right. Let's see. Next, why don't we go? Let's see. Colby. Yeah, Colby. Do you have Colby's question? Okay, so
Yeah, it should be up there.
Colby's son, Celestio, can the DKS procedure damage the electrical system of the heart? If so, would kids who get this operation have a higher chance to need a pacemaker? It's a good question, Colby. The answer is no. So the DKS, it doesn't matter what it stands for, but basically involves connecting the pulmonary artery to the aorta. And that's all done. And Colby's son has had a Glenn operation already and is going to the next one, which is the Fontan. And there's been some debate as to whether he needs this DKS thing, which is connecting the pulmonary artery to the aorta as opposed to just tying off the pulmonary artery. But that operation, it requires stopping the heart, but it doesn't require going inside the heart. And so the electrical wiring system of the heart is inside the heart. So you really have to be in the wrong place to damage the electrical wiring system if you damage it with a DKS. So that's not a consideration. There are other considerations, but that's not one of them. Does that answer the question, or do you have any others?
Excellent. No, that was something my wife was asking about, and she brought it up several times, and I kept forgetting to bring up, so I was not really sure if it had anything to do with it.
Yeah. Okay. Have you guys decided yet?
Well, so we'll still probably have a conversation with you soon. We're still on the fence. I still haven't talked to our cardiologist, which I feel is kind of ridiculous. I don't want to say anything bad, but me and you talked quite quickly, and now this has been almost a month since that phone call, and we're supposed to talk to her on Friday.
Yeah. Okay. Well, all the best.
Thank you.
So the next one we'll go to is where did she go? I just lost her. Hamed. Let's do Hamed next. I have him on the list. So Hamed, if I remember correctly, you're from California, right?
Hi, doctor. Yes, that's correct.
And your baby, who is now how old?
She just turned 5 months and she weighs around 16 pounds.
Okay, 5 months and 16 pounds, so around 7 kilos for the Canadians in the audience. So Hamed's baby has double outlet right ventricle with transposition, TGA, ventricular septal defect, and pulmonary stenosis. The VSD appears to be inlet with outlet extension in the subpulmonary region. Plan was to do an Nakaido Rastelli around the age of 1. The latest echo shows that her pulmonary valve annulus, the annulus is sort of the ring that the valve tissue lies inside of, measures 2 millimeters, but at birth it was 4 millimeters. There's tissue under the valve that has quote unquote shrunk it. My question is whether the annulus is 4 or 2. Doesn't seem logical for a valve to shrink. We were told the annulus size is important for the type of surgery. So, yes, annulus size is important for the type of operation only if you're going to save the valve. So, if you're going to do an operation like that involved an arterial switch operation, and you were going to make the pulmonary valve into the aortic valve, which doesn't seem like the case here, then that annulus size would be important. But it's not anymore. If you're going to do a Rastelli versus a Nakaido, both of those operations involve sort of getting rid of the pulmonary valve in one way, shape, or form. And with the annulus being smaller, like my my predilection would be to do a Rastelli operation because it's easier and has less complications. Both of them involve a conduit, meaning you're going to put an artificial tube in between the right ventricle and the lung arteries to bypass that bad pulmonary valve. So it doesn't really matter if the annulus is 4, 2, whatever. It's small. And could it shrink? Well, no, it doesn't shrink. The annulus doesn't shrink, but the valve opening can get smaller with time if the pulmonary valve becomes tighter, which is not uncommon. So what they're calling an annulus versus what might be the opening of the valve, I don't really know because I haven't seen the images. But again, the pathway of blood from the right ventricle to the lungs through the valve can definitely get smaller as the child gets older, which is one of the reasons that we sometimes wait on making a decision on these kids if they're fine at birth to figure out what that pulmonary valve is going to be. And the tissue underneath the pulmonary valve can contribute to that narrowing of the channel between the right ventricle and the lungs. So again, yes, it can shrink, but it's not important for the type of surgery if you're doing a Rastelli operation.
Okay,
Does
thank
that
you.
make sense?
No, that makes a lot of sense. The only other reservation I had, just reading of some of these studies, I know they're old. They're saying like for Rastelli, there's like, I think there's like a Boston study that after 20 years, there's like a less than 50% chance of survival. With modern imaging and, you know, surgical techniques, has that improved, or do you think it's still?
That Boston study is crazy old. So I'm not sure I'd put a lot of credence into that as far as modern results go. At the same time, you know, like I have to tell you the truth, like anytime you're doing a Rastelli operation, you're putting a conduit in, right? So you're putting a conduit between the right ventricle and the lungs, which is artificial, and the baby's going to outgrow that. So you're committing the child to a life of heart surgery, several more operations to replace that, and repeat heart surgery is risky. There's just no cutting through that. Now, I mean, you're at a good place. I think you said you're at USC, right? Like Von Starnes is the surgeon?
Yes, that's correct. And he's still leaving the options open for Rastelli or Nakaido, but it seems like if the annulus, you mentioned if it's smaller, then it's most likely Rastelli, right?
Yes, yeah, I would agree with that. And Von Starnes is an excellent surgeon, very well regarded. So you're in very good hands. And you know, as far as long-term survival statistics, like nobody can tell you that your child's going to have a normal quality of life or a normal quantity of life. But I can tell you that the chances of a good quality of life are very high these days. And as far as quantity, that depends on so many other things. So it's hard to know 20 years down the road or 30 years down the road what's going to happen. I mean, there's so many kids that are 20 or 30 or 40 or 50 years down the road that shouldn't be, that is really difficult to tell. And a lot of those long-term studies originated back in the 1970s and 80s and even 90s when, frankly, heart surgery wasn't nearly as good as it is today. So I think you just have to take all that stuff with a little bit of a grain of salt. I'm not trying to put an excessively positive spin on it, but at the same time, you shouldn't be demoralized by old studies that say X number of these children don't survive, because that's not necessarily true these days.
Thank you.
Okay, let's see. Whitney. You have Whitney's question? Are there any medical advances being done to prevent liver damage to Fontan patients? Other alternatives to the operation? Our son's left ventricle is severely hypoplastic, so we're not optimistic that he'd be a candidate for complex biventricular repair, but are hopeful there may be other options in the future since he's only 11 months old. So Whitney, can you just tell me a little bit about your son? Is it hypoplastic left heart syndrome?
Yes, he has hypoplastic left heart.
So he had a Norwood and a Glenn?
Yeah, he's had those two so far. And I know there's different kinds of biventricular repairs. But we weren't sure if like any of them would be viable with just how severely hypoplastic he is.
Where are you guys?
We are in Idaho. We have our surgeries at UCSF with Dr. Reddy.
Okay, so I know him too. Another very, very good surgeon. I don't think Mohan Reddy would steer you in the wrong direction, but I will tell you, and I've said it on this webinar before, that one good ventricle is way better than two borderline ventricles. So if, especially on the left ventricular situation, if it's a hypoplastic left ventricle, he's already undergone a Norwood procedure, like there has to be a very compelling reason to reverse all of this right now, because the last thing you want to do is him to be in a worse situation if he's a good Fontan candidate with somebody trying to stretch a hypoplastic ventricle into something that may or may not work, because too many of those kids end up in a much worse situation. So the Fontan operation is much different than it was 10 or 20 or 30 years ago. That's not to say that there still aren't long-term complications, and the liver is certainly one of them, because the liver is subjected to higher pressure than it would be in a biventricular circulation. What has changed, and there's no way to prevent liver disease in Fontan patients in August of 2024. But there is a way to monitor it better than it used to be. So it used to be that we didn't monitor it at all. And then we monitored it with stupid things that didn't really matter, like liver enzymes and stuff like that, that when they got all wonky, it was too late anyway. And so now people have come to recognize this. And so they do things that are much fancier, things like fibroscans, which measure the amount of scar tissue buildup, for lack of a better way of saying it, in the liver. And they do those things early on. And so if you find stuff early on, there's things you can do to the circulation, there's medication you can give, there's different interventions that you can do that can mitigate against some of the liver damage. I'd be hard pressed to say you can prevent it all, but you can treat it better if you find it earlier, which is the case nowadays. Now, your son's only 11 months old, so it's going to be a long time till he's had 5 or 6 or 10 or 15 years of Fontan pressure on his liver. So hopefully things will be better by then, because they're a lot better than they were 15 years ago. But there's no way to prevent liver disease in a Fontan patient. Having said that, again, with hypoplastic left heart syndrome or variants thereof, you have to have a really good reason not to go down the Fontan route if you've already had a Norwood and a Glenn. So liver complications aside, there are other complications that are worse on the biventricular pathway. Does that help?
Okay. Yeah. That's something that they had mentioned when we were there. Obviously, we're not there much since we live in Idaho. So we don't have regular meetings with our surgeons, but they had said pretty much the same thing as you did, that, one good ventricle is better than two, mediocre ones. But they also didn't have any input as to the liver disease. And that was something that we really wanted to keep up on so that he doesn't also have to have a liver transplant.
Yeah, I mean, you have to, sometimes you have to push your docs a little bit, but definitely routine monitoring or routine surveillance with these newer tests is an important thing to do. Well, his Fontan's probably not going to happen for another couple of years, right?
Yeah. Yeah.
Okay. All right. Next, let's see, we did Hamed. Andy, I don't see a question from you, Andy. Do you have one?
Hi, doctor. Thank you so much for putting all of these on. I am currently 37 weeks pregnant with my heart baby, so I'm venturing into a lot of this unknown with some uncertainty. But right now, he has been diagnosed with coarctation, mildly hypoplastic arch, semi-severe aortic stenosis, and a VSD. And at this juncture, our cardiologist has kind of said it's a flip of the coin whether or not we would need to go the sternotomy or the thoracotomy route. But then there's also.
Are you, Andy? Are you Andrea?
Oh yeah, that would make sense.
Okay, now
I do have two names. Yeah,
okay,
I don't
Tony,
remember
Tony, you wanna
exactly
put
which
up
question
Andrea?
I had, asked Tony.
Yeah,
but you
and
can
do you
pull
want
it
to
up.
put up Andrew's questions so everybody can see it?
Yeah, just give me 1 sec. I'll find it here.
So you're 37 weeks now, Andy?
Yes, yep, with an induction at 39. So it's all
Where are
becoming
you?
quite real soon. I'm in Colorado, so I'll be delivering at Children's Hospital of Colorado, and surgeon will likely be either Jaggers or Matthew.
Say the surgeon's names again.
Dr. Jaggers or Dr. Matthews?
Okay, I know Jaggers. I don't know Matthews. Must be new. So, okay, so this question: transverse aorta, isthmus, aortic annulus, determine thoracotomy versus sternotomy. Anything to do about the narrow aortic valve are likely to monitor potential intervention down the road. Expected time frame. Okay, so there's a lot to unpack in this question. So the first thing is, do you know the size of the left ventricle or the mitral valve?
Mitral valve is somewhere in that -1.5 z-score. The left valve is definitely smaller, but they're saying it seems to be growing okay, apex forming.
So they haven't talked to you. They haven't talked to you about single ventricle. They think your baby's going to be good with what's called a 2 ventricle repair.
Yeah, they've been focused on the 2 ventricle repair. However, that is a question on like when do they determine if they would need to go the Norwood route and still pursue biventricular down the road? Is it based off of the systolic function, or is it based off of these z-scores? Like, what are they really going to be looking at once baby's here to make those kinds of 3 different pathway decisions?
Right. So that's why I asked about the mitral valve and the left ventricular size. So it all depends on the left ventricular size, the mitral valve size, and the aortic valve size, as well as the characteristics of the left ventricle, the tunnel between the left ventricle and the aortic valve. There's all sorts of things. So the best way to measure all this, I mean, in utero testing is fine, but the best way to do it is after the baby's born. So by echocardiogram, and sometimes fancier tests like CT scans or MRIs to measure the size of the left ventricle if it's really borderline. So, but again, as I said before, like these decisions, probably the most important decision in your child's life, and I don't mean to sound dramatic here, but the most important decision is which pathway to go down at the beginning, because it's really hard to switch directions, like really hard. And I'll just tell you, like I've made this mistake both ways. I've made the mistake of assuming it's a 2 ventricle and going down that route and regretting it, and made the mistake that it's a single ventricle and going down that route and wondering. It's hard to regret that, because usually if it's you go down the single ventricle route, most of the time you're not going to pay the same price unless the operation goes poorly or the kid doesn't survive a Norwood operation. But if you go down the biventricular route and you're wrong, it's really, really hard to backtrack. Now, having said that, like, I don't know what the measurements are now. These measurements are compatible with a biventricular repair as long as the mitral valve is okay and the left ventricle is okay. If the left ventricle is really small or the mitral valve is really small, then I'd be worried. But let's just assume for a minute that that's the case and we're going to go down the biventricular route. Then your next question is thoracotomy versus sternotomy. So now you're talking about the coarctation of the aorta. So there's a little bit of controversy, I guess is an okay word, about this. Frankly, I think the older the surgeon, the more likely they are to do a thoracotomy. Like I've rarely had to do a sternotomy to fix a coarctation, because if you know how, you can enlarge the whole aortic arch using a thoracotomy, and you don't need to go on the heart-lung bypass machine. So I think it's highly, highly preferable to do it using a thoracotomy versus a sternotomy. You'd only do it with a sternotomy if A, you had to do something else inside the heart, which I doubt you have to do right away, or B, the aortic arch is so tiny that you have to enlarge it and you can't get to it through a thoracotomy. But if you're doing that, then you have to wonder if the biventricular repair or just doing the coarctation and not a Norwood is the right thing to do anyway. So I would say under the vast majority of circumstances, a coarctation can be fixed with a thoracotomy. And there's lots of different techniques you can use to fix a coarctation, to enlarge the aorta from a thoracotomy approach. And for those of people that don't know, a thoracotomy means making an incision in the side of the chest as opposed to making one up and down the breastbone. So most of the time you can do it through a thoracotomy. Now the narrow aortic valve, that all depends on how narrow it is when the baby's born and what the left ventricle is doing. So sometimes the aortic valve is fine for years. Sometimes it's not. And usually, not always, but usually the first intervention these days is a balloon valvotomy. So a cath lab procedure to stretch open a stenotic or a small aortic valve. And that sometimes is required early on in life, early on meaning in the first week of life. And sometimes it's not required until 6 months of age. Sometimes it's not required until a year of age. Sometimes it's not required at all. If it's required, there's a high likelihood that it won't last and that an aortic valve replacement will be needed. But that time interval between balloon and aortic valve replacement is extremely variable. I've seen kids, I've operated on kids 6 months later, a year later, and 15 or 20 years after their balloon. So sometimes an early balloon can last all the way up until early adulthood. So it's very variable based on the characteristics of the aortic valve, the result obtained from the balloon, and all the rest of it. So it's difficult for me to answer the question specifically, but know that there's a huge range there.
Sure. No, that makes a lot of sense. And I mean, I guess the balloon valvotomy would be the first step. Under what circumstances and what age is that Ross procedure that you were mentioning before appropriate, or is that really only for very severe cases where you don't necessarily want to do a full valve replacement?
No, a Ross procedure is a full valve replacement. It's
Well,
just replacing the valve.
yeah, rather than using an artificial valve, I suppose.
Yeah, so a Ross procedure is actually a much bigger operation than a valve replacement because it involves taking out the patient's own pulmonary valve and transposing it into the aortic position. And to do that, there's a lot of other steps. You have to detach the coronary arteries, the arteries that supply blood to the heart muscle, and then reattach them. And then you have to replace the explanted pulmonary valve with what's called a homograph. So I've done that operation on kids as small as 5 kilograms, and I've done it on plenty of adults too. It's one of those things that most good pediatric surgeons have some knowledge of and experience with. Most adult surgeons don't, because they don't like that operation, because it's a lot easier to just do a valve replacement, but it's doable in any size patient. We like to avoid it if possible until the child's a little bit older, for the primary reason that when you do it, like I said, you have to replace the pulmonary valve with a homograft, and that homograft is cadaver tissue that doesn't grow. So if you can do that operation optimally in a, let's say, an 8 or 9 year old child, then they probably won't need another pulmonary valve replacement for a long time. If you do it in a 1 year old, they're going to need a pulmonary valve replacement sometime in the next 5 to 10 years. If you do it in a child less than 1 year of age, they're going to need that pulmonary valve replacement even faster than that, because as you know, the rate of growth of children is way different in the first 6 months of life, and then between 6 months and a year, and then slows way down after that, right? Like They grow like a weed early on, and then they, relatively speaking, slow down.
Got it. That is really helpful. I
All
guess
right.
my last kind of clarifying question is, so overall, you would prefer to do a thoracotomy through and through because you
Yes.
can still access a good amount of the aortic arch, even if you may need potentially some balloon recoarctation intervention later on versus the sternotomy because of the risks of the heart-lung machine.
Yeah, and I'm going to say something that probably shouldn't, but I guess this stuff goes on YouTube, so people can look at it anyway. But the whole recoarctation thing, that the incidence of that should be really low. It doesn't really have to do with the extent of aortic arch reconstruction that goes on. It has more to do with surgical technique. Again, I tried to say that politically correctly. Oh, one other thing, Andy, because you're in Colorado. So the one thing I will say is that because of your altitude, there, and this is a real live concern. I interviewed in Salt Lake City one time and learned all this, but the propensity or the bias to do biventricular operations in some of these cities that are high in altitude is higher. So some surgeons try to avoid single ventricle operations in high altitude places because children tend to struggle a little bit more at altitude with single ventricle anatomy.
Oh, that's really interesting. We'll keep that in mind as we're chatting with the doctors and surgeons in the future, but really appreciate your time. Thank you so much again.
Yeah, hopefully you don't have to go down that route anyway. Okay.
Fingers crossed.
Paul and Catherine, I don't see, oh wait, I haven't opened the chat. There's a bunch of chat questions. I haven't seen a question from you. Do you guys have a question?
No, we're good. We're just checking in, saying hi to you, but and just learning some other stuff, but we're good.
Okay, great. Okay, so let me go to the chat. So first one's from Caddy. My child's hemoglobin has gone up from 14 to 16.8 in the last year. She has pulmonary treason, tachyventricular septum, Glenn stage unrepaired. We're discussing the next surgery. Cardio told me that if her hemoglobin is up, and it's another indication that she needs to go for her repair, which involves closing the ASD, putting it in a pulmonary valve. I'm trying to delay it as much as possible. Could phlebotomy help manage the risks of a high hemoglobin while we delay surgery for a few more years? Yes and no. So yes, phlebotomy can help, but it's very short-term fix because the body's going to compensate quickly for it. And if the hemoglobin continues to rise, that is absolutely an indication for an operation. So there's no getting around that. The other question you had, Caddy, on the thing, oh yeah, here we go. Partial heart transplants for pulmonary valves. It's done for other valves at Duke. I don't know what that is. I don't know what a partial heart transplant is. So you have to educate me on that. I've never heard of it before.
Yeah, hi, Dr. Gandhi. It's this, like, I was reading really, but I think that they do it really like for other valves, that it's the right side like valves of the heart. And it's basically like a live transplant. So they pick really the pieces of a live donor. And they just transplant this, and like they've done some.
I think you must have misread it, Caddy, because there's no such thing as a live donor. To be a donor, you have to be dead.
Yeah, but like what I mean is kind of like you get like the heart really as soon as like the person dies, so you transplanted that, and it's not really a cadaver donor, so it grows really with the patient. And some kids really had this operation already, and apparently one of them has been like with immunosuppressants, like all these like reaction medicines for a year, I think, and then it was taking off the whole thing, the whole medication. It's doing just fine. And the other kid
yeah, maybe you can send me that stuff, because that's That's above my pay grade. I'm not familiar with any of that. It doesn't
Okay.
intuitively makes no sense to me, but I'm more than willing to be educated, and I clearly don't have all the answers. So maybe you can just send that to me, and I can look it over and then answer it next time.
Okay, thank you.
Okay. Okay, next question. Follow up from Colby. Another question regarding liver complications. A cardiologist mentioned that with the DKS, it can prevent liver complications or reduce them. No, I don't get that. Liver complications are due to the Fontan. If the DKS is necessary because you might have outflow tract obstruction, that will cause a whole lot of problems. The liver, I suppose, could be one of them, but there's no direct correlation between a DKS and the liver. Next one is from Whitney. Follow up on the biventricular repair question I had. Boston Children's has been doing a reverse 1.5 ventricle repair for hypoplastic left heart syndrome. It says on their website the kids with severely hypoplastic left ventricles can maintain the Norwood Glen setup and tunnel only the IVC to the left ventricle and reconnect the left ventricle to the PA. It sounded promising, but maybe the Fontan is better overall due to the invasive nature of the reverse 1.5 operation plus repair of non-functioning aortic mitral valves. Do you know anything about this procedure? No, I don't. But you could send me that too. I will say, listen, Boston has been one of the institutions that has been at the forefront of sort of pushing the envelope. And they, back when Lisa and I worked in Pittsburgh, started doing these borderline single ventricle, turning them into biventricular operation kids. And the results they published were really good. But when you talk to the people in Boston, they hated it. And there were a lot of results that didn't make it, I think, into the publications later on. So I always encourage certain institutions pushing the envelope, because without that, you don't ever learn anything and make it better for these kids. But this sounds quite circuitous, pardon the pun. So I'd have to read about this one too. Like I don't know what the intuitive benefits are of this whole situation compared to a Fontan. So I'll have to play dumb on that. Also, speaking of high altitude, will those struggles get better after the Fontan? Our son is fine at 3,000 feet in the mountains. His oxygen drops to the high 60s while sleeping, but he's okay while he's awake. Well, I suppose it will get better as the body acclimates to it and naturally increases the body's hemoglobin, like like those cyclists that train at altitude do. But I don't know enough about it from the long term to know what happens to these Fontan kids years later that live at altitude. But in theory, I think you're probably right. Okay, Hamed, we've been told that since the VSD is inlet with outlet extension, a 2 ventricle repair is possible, but also 1.5 ventricle repair if they do Rastelli, since the RV will be smaller. Is a 1.5 ventricle repair similar to a biventricular repair? No. So in this context, there's a lot of different types of 1.5 ventricle repairs, but in this context, what they're talking about is the RV being too small to support the right side of the circulation. So again, to go back to basics, the right ventricle sends the blood to the lungs. Same amount of blood that comes back from the lungs to the left ventricle is sent to the body by the left ventricle. If the right ventricle is too small and not able to handle all of that blood getting pumped to the lungs, then the way to what's called offload it is to do a Glenn operation in addition to the Rastelli. So you take away half of the blood flow returning to the right side of the heart. So you take the Glenn means you sew the upper blood vessel, the superior vena cava, the blood vessel that drains all the blood from the upper part of the body. you sew that blood vessel directly to the lung arteries. So it doesn't have to go through the right ventricle to get to the lungs. So the right ventricle doesn't have to do that work of pushing that blood to the lungs. So that's why they call it a 1.5. It's not technically 1.5, but that's the terminology used. So all that blood gets to the lungs directly using gravity, but the right ventricle still gets all the blood from the lower part of the body to the lungs through the normal pumping mechanism. Does that make sense, Hamed?
No, that makes sense. Thank you. In terms of just like quality of life, we were told that would be similar to a bivent and better than a single ventricle, but I don't know if that's accurate or not.
Yeah, I don't know. I mean, quality of life is such a subjective thing. I think that in theory, the liver complications are not going to be present because you're not subjecting the liver to Fontan pressure. So it's better than a single ventricle for sure. Whether it's as good as a biventricular repair, I mean, I don't know. I just don't know. But I mean, it's better than having a right ventricle that doesn't work properly because it can't handle the whole load of blood.
Thank you.
Colby has another good question that's often asked. Fontan question, can a low-fat diet pre-Fontan reduce the risk of developing chylothorax post-surgery? No. Everybody thinks that, but no. And I'll tell you what I did. Lots of people try to avoid the whole fat thing post-op to avoid chylothorax. I encouraged it. Like I wanted the parents to bring as much ice cream and high-fat milk as possible the first few days because I wanted to know if a chylothorax was going to happen. Because if it happens, it's better that it happened earlier and then you deal with it rather than to screw around for a few weeks and then it happen, you know, later or when the kid's home or whatever. You want to. I always. Some people hated me for doing it, but I always tested it early. And then if it happened, you dealt with it. And if it didn't happen, great. And chylothorax is a pain in the butt post-Fontan. It just happens sometimes. But rest assured, they all get better with time. Let's see.
Dr. Gandhi, we got one question on the slide I can throw up from Woodrow.
Oh, okay. Oh, I'm sorry, Woodrow. I totally forgot about you. You're patiently waiting from the east coast of Canada. Our son Maverick completed his heart transplant assessment in July at Sick Kids and had an AV fistula operation at the same time. We have many questions, but I guess the one we'll ask for now is how do we know it's the right time to list Maverick for his transplant? So for everybody that hasn't been on the call when Woodrow's talked about Maverick, Maverick has single ventricle anatomy, had a Fontan, didn't work out. Fontan got taken down, and now he's undergoing a heart transplant evaluation at Sick Kids. And due to increasing cyanosis, he recently had this AV fistula operation, which is where you connect an artery to a vein to increase the amount of oxygen in the blood. It's sort of a cheap way to get higher oxygen saturations. Did I summarize that correctly, Woodrow?
Perfectly, yeah, very good.
Okay, so so your question is like an excellent question. It's the $1 million question. So I'm going to give you my bias on it. The fact that he needed an AV fistula or somebody determined that he needed an AV fistula means that he's borderline functional as far as his physiology goes. He might be doing fine. I don't mean to suggest that he's not, but physiologically, there's something that needed augmentation. That's why he needed an AV fistula. The problem with a heart transplant, the biggest problem with the heart transplant, the biggest initial problem with the heart transplant is getting the damn heart. So, and there's a lot that goes into that. Part of it's his blood type, part of it's the wait list, part of it's his antibodies that he might have, his size, who he's competing with, like all this stuff, right? So I think if it was me, and again, I don't want to speak for the people at Sick Kids who are very qualified in pediatric heart transplantation, and you're probably dealing with Dr. Dipchand's team, and I know Ann Dipchand very well, and she's incredibly well qualified to speak on this. But if it was me, I would list him for a heart transplant now, because the one thing that you get by listing a kid for a heart transplant is the accrual of time. So time matters. If you're competing with child X and child X has been waiting 3 months and you've been waiting 6 months and everything else is the same, then you get the heart. Now, just because you get the heart doesn't mean you have to say yes to it either, right? So just because you get a heart, you can pass on a heart for whatever reason. We pass on hearts all the time because the kid's not ready or the heart's not good enough or whatever, the phase of the moon, like whatever it is. So, but accruing time is really important. And I always told parents that, you know, I'll let God make this decision. Like if they call me up and they say, you know, this is a perfect heart, the travel time is minimal, the downtime of the donor is minimal, it's a perfect size mismatch, it's a perfect antibody mismatch, all the rest of it, like somebody's telling me something that, okay, I better put this heart in because I may never have this opportunity again. So if there's a crack in the window, jump out of it. So I always think that when you're at this stage, list the kid and worry about it later. Now they might have told you something different.
No, not really. I think the biggest thing is seeing Maverick healthy and doing well, and that they said, you know, success rate is about 75%. But the thing that Dr. Dipchen said to us that sticks out the most is probably a healthy child going into transplant has a better chance of coming out. So like Maverick might not be healthy, but his quality of life is really good, and he's strong. He's playing sports. He still plays hockey. I guess it's just that fine line between saying, okay, let's list him now when he's healthy versus if he got sick. And I think her point was, you know, some parents wait too long, and you're in the ICU, and then you say, okay, we'll list him now, but it's too late. I think that's what we're fighting with.
That's an excellent point. You never want to wait till you're in the ICU. Like
Right.
It's much better to transplant a healthy at-home kid than it is to transplant a kid that's in the hospital struggling.
Okay.
So if the determination's been made that you need a transplant and you're not sure if it's going to happen in 6 months, a year, or 2 years, then yes, I'm all for listing and dealing with it when the offer comes.
Awesome. Thank you so much.
Sorry, your question was way up there on the list and I somehow just passed you over. Whitney, I got that YouTube link. I will watch it later, and maybe you can send me an email so I have your email address and then I can respond. All right, Tony, did we get through everything?
I think so, yeah. I believe that hit everybody on the list that is here, plus all the messages thrown into the chat. So I think we're good.
All right, thanks everybody for coming. We'll do this again in September.
Thank you.
Yeah, we have, if you guys can go to Dr. Gandhi's website, drsanjivgandhi.ca, it has all the registration stuff on there now, so you can register for the next one. And we'll, of course, send copies of this out to everyone that attended. And Dr. Gandhi's email address is in there as well. So if you guys have any questions, just reply to that. You'll get straight to him and you guys can take next steps from there. So appreciate it, everybody. Thanks for your time.
All right, good night. Tell your friends. Bye.